Brilliant. So good afternoon, everybody, and apologies about the technical issues, but that's of course nothing to do with the antimicrobial team or anything to do with NAPS. But it is really lovely to see you all both here in the auditorium, but also online. My name, if you haven't met me, is Shelley Dolan, and I'm the very new Chief Executive at the Royal Melbourne Hospital. And I'm really, really pleased to be here today to launch an area that has been part of my professional practice for many years. But before I start today's official proceedings, can I acknowledge that wherever we meet in Australia, we meet on the lands of its first people, this way, yeah. Sorry, and I pay my respects to their elders past, present, and for their enduring connection to this beautiful country. And I would like to welcome any First Nations people joining us this afternoon, or here in the lecture theatre, or via the live stream. So to everyone joining us, Wominjeka, thank you for meeting today on the lands of the Wurundjeri people of the Kulin Nation, land that has never been ceded. So, as I said, I'm delighted to be here as part of the Antimicrobial Awareness Week. As Kaz knows all too well, I started life as an intensive care nurse, and my MSc and PhD was all about sepsis. So this is a really, really important subject, as you all know, otherwise you wouldn't be here. But I think we all recognise the extraordinary contribution of the National Antimicrobial Prescribing Survey to the health and well-being of our community over the last 10 years. We all know that over the years, the effectiveness of antimicrobials has been eroded. And when we use prescribed drugs inappropriately, we not only cause harm to patients here now, we also cause harm for the future. So in the face of this mounting challenge, the Royal Melbourne Hospital Guidance Group has stood resolute for over 15 years at the forefront of this battle against resistance and stewardship, earning well-deserved recognition as international role models and working with collaborators. This extraordinary group embodies the power of multidisciplinary collaboration, highlighting that we are always better together when we focus on some of the big problems. In continuing their relentless pursuit of solutions, the visionaries and probably people with quite a lot of stubborn kind of, will to keep this going, didn't stop there. They went on to create the National Centre for Antimicrobial Stewardship, which is a beacon of excellence that is recognised globally. There are also two incredible homegrown products that have emerged from the Royal Melbourne and were nurtured by the ingenious minds of this group. The National Antimicrobial Prescribing Survey, or NAPS. And NAPS originated from a thorough understanding of clinical need and a dedication to excellence. The guidance group acknowledged the unmet clinical need and took the initiative to develop standardized tools aimed at enhancing the quality of antimicrobial prescribing assessments. Today, the NAP stands as a testament to the successful collaboration between technical and clinical expertise. Before I finish, I would like to take a moment to express my deep gratitude to Kaz, Professor Karin Thursky, for her extraordinary contribution to the global field of antimicrobial stewardship. Kaz, it is thanks to your strategic leadership, commitment, influence, and sometimes, to be honest, that she will just go on through across blockages, over them, through them, and just get there. So to you and your team, thank you for everything you've done. And to everybody, congratulations on a really successful 10 years of NAPS. Thank you all very much.
All right. Thank you everyone for being patient online. You should have seen what was going on at this end, but anyway, we're back, and thanks everyone for the patience in the room. And I am actually very grateful for Shelley. Court, can you run it?
Yeah, sorry, I don't know how to. Yes, it's clay.
So I've going to have some happy pics going as I talk today, hopefully.
No, it's Marshall. Yes, this is okay. So now I press play for this too. We've got to do this. It is, that's why I'm presenting mode is on. I'll just do the next one at the start. Yeah, okay. Oh, there you go.
All right. Okay, let's go. So thank you everyone for joining online for this very happy celebration. It really has been a pretty remarkable journey. And I think you will hear us say all the time that NAPS is not a software platform. It is not just a piece of technology. It is actually an activity that has come into the lexicon of every antimicrobial steward in the country, in hospitals and in aged care. Even our GP colleagues know about it these days. So the success really is from our end users, and for all of you online and for all of you in the room that have been using the NAPS, this is your birthday celebration just as much as ours. Every year, we know that our stewardship teams plan the survey. It's not progressing, I don't think. Yeah. And we know that its success is really due to the fact that we've been working with all of you for such a long time. But not only that, we know that the data is really meaningful. And for that reason, we have been very grateful to have the support of the Australian Quality Safety Commission and also the Department of Health to allow us to continue to do this work. And we know that being the only platform that actually measures appropriateness, we know that we've been driving policy and practice change. And really, if I reflect back on our journey from sitting in the back room at 9 East with Rod and Kirsty and Susan and Renu, and starting from the very start with just a group of enthusiastic stewardship pharmacists around Melbourne doing the very first paper pilot, and then I think it was a SurveyMonkey, Rod, the next one. It has turned into what we think is a global phenomena. And in fact, just this week, our Portuguese colleagues who translated the NAPS into European Portuguese have been doing their survey across several hospitals. And really, it's very exciting for us. We now have over 5,000 auditors from all clinical backgrounds. You know, really it is, remains globally unique in the things that it can do. And even more so, we've been able to gain the trust and build relationships with many, many hospitals and over 1,000 aged care homes. And that's nothing short of remarkable. And much of that is due to the efforts of Noleen Bennett, who's sitting up the back there, who has just really quite remarkable. You know, Shelley thinks I have drive. That's nothing compared to what Noleen has. Our support from the Commission and Department of Health have been it's really incredible. And it's really nice to know that they understand the key principles about how we do and what we do, because it is actually an activity that is considered to be very important and incorporated really into the way hospitals and aged care homes are undergoing accreditation. But behind the NAPS is a really remarkable group of people, and many of them are in the room today. And we would never have got to where we've got to without the team that you've been seeing on the slideshow. It is a really happy unit, and I come to work every week with a smile on my face because I know that they're genuinely, you know, we're working and are supportive. To be doing this out of a hospital department for 15 years is pretty crazy. And you'll hear from a lot of them today. They are, you know, we have a group of incredible stewardship pharmacists. We have incredible developers. We have our own usability expert, Shri, in the room that has really revolutionised the way we design and use a human-centred design process. And we're very proud of both our gender diversity and our cultural diversity. And I think that's something that's really important to point out. We understand that a good piece of software requires a very robust software development life cycle. And we're very fortunate to have people like Michael, who's been driving our quality management system, and Steve and Freddie, who helps us with all the challenging things around contracts and the whole business of managing a program like this. We also know how important it is to our end users that what we deliver to them is also secure, but they also have access to it for its own use, but also to drive our research. And with that research, really, the fact that we're able to build out such an amazing group of researchers, again, many of them who are in the room today who'll be talking with you, is really exciting, because that's what really drives our improvement, to have that research behind the way we do, how we drive our development. We have fully embraced the learning health systems framework and how we do things. And we understand how important it is to continue the human-centred design process. We have PhDs, postdocs and MPhil students and hopefully new PhDs, not looking at anyone specifically, who will be talking to you today about their contribution to the NAPS and to the new NAPS modules, and to how we're starting to bring data science into what we do. Now, we are exploring the role of natural language processing and machine learning. And then we're very fortunate to have Christina Bareja down today from the Commonwealth Department of Health to talk about the new Australian CDC. We await with interest how this is going to play out, particularly in the area of antimicrobial resistance and stewardship. And we're so glad that you could join us. At the very end, our very own Kaz Chen, who's leading the redesign, is going to talk about where the future holds for us. And then very end after that, we invite you to join us with the actual NAPS birthday cake. I'm sorry, everyone online, you won't get to have any, but we will show it to you, and some Prosecco. So the person now who I want to introduce, and who is very special to all of our team, and we really couldn't do what we could do without him, is Dr. Rod James. So we refer to him as the grandfather of NAPS. Sorry, Rod, you are graying a little bit. He is a program director, and he has been there from the get-go. He was the one that designed that very first paper survey, and he's been involved all the way through up till now. And we're so incredibly fortunate to have someone who is just that no challenge is too difficult. He has thoughtfully steered the program to where it is now. He is actually the co-theme lead of the AMR strategy at the Doherty, and has been educating clinicians across the Asia Pacific in stewardship and particularly in how they can use and adopt the platform. And I think where were you last week? It sort of disappears all the time. I think where did you go last time? Where did you go? Tonga, that's right, Tonga. So, and then Fiji was doing a NAPS this week. So on that, I'm going to finish and welcome Rod, who is going to give us a bit of a cook's tour of how we got to today. Thanks, everyone. We'll show it after.
Thanks, Kaz, for that. I'm not sure if I really appreciate being called the grandfather, but as you'll see from the photos, I have got a lot grayer since I've been working here. I think mainly because Kaz drives me so hard. But we'll just wait for our slides to come up. But thanks to everyone for coming today, both in person, but definitely online. We do know that we are a online service, and we do try to provide a service to everyone via our amazing support team. But today I just really wanted to give you some highlights of where we have come from over the last 10 years. It's been a very exciting journey. I think a lot of you have come along with us. We do know that some of our auditors have been there from day one. Some are in the audience here today and some are online. So hopefully you can have some understanding of where we've kind of come from in our wonderful journey. Okay, so where did we really start? So I guess where we started was from really some quite humble beginnings. We were just a very, very small research organisation in Melbourne Health. And Kaz and Kirsty got an NHMRC grant to really understand how antibiotic stewardship programs could be implemented in various settings. In metropolitan settings, private hospitals, public hospitals, and rural and regional hospitals as well. And this is where we kind of really started. We did lots of in-depth interviews. We went out to regional remote hospitals, myself, Susan Lou, and Mignon Event for some people, and we really got an understanding of what was happening in Australia in these settings. We really wanted to understand how they could implement stewardship programs, what was the barriers, what was the enablers, and really what did they want from an organisation such as ourselves. And what they came back with is they wanted auditing tools. They wanted to be able to do something standardised, which could really be very helpful to them in a very meaningful way to provide the data which they wanted for their stewardship programs. This kind of came about really from their very first publication back in 2011, which was the Antimicrobial Stewardship in Australian Handbook. And this was put out by the Commission back then and gave some really good examples of implementation strategies and resources around setting up stewardship programs. And this is where really the idea came from to help these facilities set up a good program. And part of that was also that the standards came out at the same time. And for the first time, stewardship was really front and centre in these standards, and monitoring of antimicrobial usage and resistance should be undertaken. So we really wanted to help these smaller facilities produce I guess from their point of view, an auditing tool which they'll be able to use to help to meet these accreditation standards. So where did we start? So we first looked at what was out there in the sphere and what there was with the global PPS. So this was an auditing tool run out of Europe, which looked at a point prevalence survey, which really collected data on the antibiotic use within the facility. We tried this, I guess, within our own facilities and found that it wasn't particularly useful for the Australian population and didn't really meet the requirements for those standards. So we started off with a couple of initial pilots to see if we could come up with something which is a bit more appropriate. This was, again, an activity on Antibiotic Awareness Day. It was a day back then, not a week. So we have moved up to a week. And we really looked at paper-based surveys where people could then enter data into a SurveyMonkey platform. And I pretty much sat up late at night, each night, tabulating this data and sending reports back to people. For the first facilities, there was 32 back in 2011 in Queensland, New South Wales, Victoria, Tasmania, and South Australia. And we really called this the APS, the Antimicrobial Prescribing Survey for Australia. Then in 2012, word got out, and suddenly we had 85 facilities, and every state and territory in Australia was represented. So this is a really fantastic idea that what kind of we thought might work really expanded, and people adopted it very, very quickly. We then took feedback from these surveys, really said, well, this is, good. We're doing paper-based surveys. It's through SurveyMonkey. I'm going grey, trying to analyse all the data and get it back to you on time. But what do you really want? And this is where the philosophy of NAPS has really come about. We ask the users what they want. The feedback was very positive. There's some constructive criticisms and suggestions, but really what they wanted was the ability to perform data electronically, but be flexible how they perform the audits and also have some ability to benchmark. And again, if you want to read it, this is the first report we put back out in, I think came out in 2015. And it was really the first time we had a snapshot of what was happening in Australia from a stewardship point of view and what our appropriateness was in Australia for antibiotic prescribing. Then in 2013, we decided to do what the users want and create an online platform. We didn't know how to do this ourselves, so we collaborated with our awesome partners, Vicness, and myself, Caroline, Simon, Roland, sat in a room about Christmas time and over a 2-month period, created the NAPS platform. So really we took that original idea of the APS. We've now been in every state and territory, so we put an N in front, called ourselves the NAPS, and the NAPS was born. Unfortunately, we had a very ugly logo back then. We have improved our processes slightly and things are looking a lot better these days. But we still needed some funding. So around the same time, we asked the Australian Commission on Safety and Quality in Healthcare to assist us with some further expansion. They were very, very helpful in that. And they funded us as an ongoing program for many years after that. And really the aim of the program was to provide a quality improvement tool in an online format to help hospitals audit their antimicrobial prescribing. We provided data on an antimicrobial prescribing behaviour in Australian hospitals and allow for some comparisons through some benchmarking. and assist in identifying areas for improvement. And that's really where we kind of came from, those three key areas. And still today, those three key areas are very, very important to us. The platform is open to any hospital within Australia, rural, regional, private, public. And in 2013, to coincide with Antibiotic Awareness Week, the program was launched and the online platform was live. But again, just to emphasise, it was really just four of us, Kirsty, Kaz, and myself. Very awkward having two Kazs in the one organisation. But yes, it's been an amazing journey since then. And as you can see, I didn't have much grey hair, but nor did Kaz or Kirsty.
It's still done.
So we started off with a quite basic program. It was very flat. Remember, anyone back then, we had a very similar auditing tool. It has changed slightly. But I guess really the key of our survey, which is different to the rest of the world's, was we really looked at the appropriateness of antimicrobial prescribing and did that in a very meticulous way with a matrix so that it was done consistently across all facilities, which then allowed for that benchmarking. But even today, really the NAPS is the only international audit that looks at the appropriateness of prescribing. So I just want to touch base with, I guess, the timeline of the NAPS. So we've started already that back in 2011, we did our first APS survey, and that was on SurveyMonkey. By 2013, we'd released our first audit, the hospital NAPS. 2015, because we knew that also auditing and aged care needed some review, so we launched the aged care NAPS. And again, thank you very much to Noleen for her amazing support throughout the years. 2016, we doubled our audits and had the surgical NAPS and quality improvement NAPS. And in 2022, we released the Antifungal NAPS survey. So our program has really grown quite significantly over those years, and to really meet the needs of a society where antibiotics are being used, I guess, in ways where we want to try and improve them. But anyone who has been on our platform, we can see all those wonderful audits we have, but there's always been this very strange green box with a grey veterinary NAPS, which is unclickable. And it's been like that for 10 years. And we do apologise for that. It's not that nothing's been happening. Along the way, we have done many pilots. So we have been doing pilots in the veterinary sphere, and that's been since 2016. And we've got some data on some veterinary prescribing. We performed a hospital in the home audit, which is very successful, again, looking at how prescribing is done in that setting. We've done lots of research into how general practice can improve their prescribing through similar surveys, and we'll hear a bit more about that later today. We look not ignoring our Indigenous population, and we did some pilots up in the Northern Territory, Northern Queensland, Northern WA, into some of those prescribing practices. And more recently, we've even started to look at how dental prescribing can be improved and how maybe a dental NAPS might be on the cards as well. So we are definitely looking at seeing how prescribing is done across all areas of prescribing. We're not just concentrating on hospitals, and hopefully we can get a better understanding of the appropriateness of antimicrobial prescribing within Australia. But 10 years on, really the NAPS has been instrumental and fundamental in shaping Australia's national AMS landscape. This is either by directing policies or reacting to them. And quite a few of those kind of national Australian strategies, the accreditation standards, aged care standards, even working with the therapeutic guidelines to improve some of those guidelines, working with the Commission for many years, and more recently working with the AURA program for a national surveillance system. So along the entire journey of AMS within Australia, the NAPS has been quite integral. And I guess it's really all started from our basic philosophy, and this is really facility first. We wanted to make a local quality improvement program, particularly for facilities, so that they could audit their own prescribing practices. And I think this is really where the NAPS is highlighted, that it's a user-friendly service where we really want facilities themselves to get some local data for local improvement initiatives. But then at the same time, do some peer comparison, and we've had our inbuilt benchmarking facility within the NAPS, so you can compare yourselves against not only the national data, but like facilities, and really hone down to a more appropriate kind of peer comparison. There's jurisdictional reporting, national reporting surveillance with the AURA program, and also we've got a huge database for research. So although we start off with making sure it's a program useful for facilities, once the facilities are using it, we can then use this data as an ongoing process. And along the way, we've had many NAPS research going on into surgical prophylaxis, ophthalmology, aged care, sepsis, neonates, pediatrics. I can't name all the different research organisations who have come and used our data to help inform policies and improve the understanding of AMS within Australia. Then we do have a national reporting, so we've had 21 national reports, 5 AURA reports, and now with our first starting our NAPS, our circulars to really improve the ability to understand data and make it more implementable. But we do use everything in a learning health system. We didn't know it was called a learning health system when we first started, but more recently we've had an understanding. But we do always go back to our users, go back to the literature, looking at strategies, our strategic partners, and really perform a auditing program, which is meeting the needs of our users. The real benefits, it's custom made by clinicians for clinicians. So we are all clinicians who are building the survey. It's standardized, so we make sure that all facilities are doing it the same way, so you can get that national reporting, but also the benchmarking. It's flexible, so we do allow facilities to have a bit of flexibility around it, so we do know that that's very important, and we want to keep that with any kind of processes. Accreditation compliance, so we make sure we do keep up with accreditation services, so we do know it does meet the accreditation requirements of both hospitals and aged care. And it's well supported. So if anyone's called the support line or emailed, we do know that you do get a response fairly quickly. And that's really because of our amazing support service that's been working over many years. And if anyone's contacted our team, any one of these people might have got back to you. And they've been a fantastic support throughout the years, not only from a, I guess, technical and auditing program, we're there for our clinical support as well. We've answered many clinical questions throughout our years. So really gets a 10-year comparison. Back in 2013, when we first started, it was a single module, single country with 130 hospitals. But we've really branched out into 5 clinical modules within 13 countries. We've got over 2,000 participating facilities and increasing size and complexity of data with over 1 million lines of data in our database now, which, as I keep saying, is open for research if people ever want to utilise that data. But I guess finally, what we really want to thank is a big shout out and thank you to all the auditors and our contributors out there, because without you, we really wouldn't be this service. We do know it's very hard to audit. It's very time consuming. It's relying on people who don't have much time to actually put this effort in. So we really want to say thank you, and we could not have been anywhere without you guys. All right, so let's congratulate the NAPS on a 10-year anniversary. I think it's been a fantastic job. We've got a much bigger team now, which I think is really good to see. And so hopefully we'll have another 10 years in front of us. So what's next? Well, you hear from a lot of talkers now. Hopefully we can get through them all. We'll hear about the Australian CDC from Christina, aged care NAPS from Noleen, antifungal NAPS from Anna, and some NAPS in understudied populations by Courtney. We're looking at NAPS in primary care by Jo-Anne. The NAPS goes global by Ron. NAPS and AI, are we ready? Which I think is a very exciting one everyone wants to hear about from Daniel, and really what is ahead in the next 10 years from Caroline. So thank you very much. Interest of time, I think we'll keep moving, but thank you so much.
So it's clicking here, but I know it doesn't change, but it is what you see here, what's up there.
Okay, great. Thank you.
you.
Hello, thank you first of all to the Kazas and to Rod for the invitation to come and talk about NAPS, its role in AURA, and also the exciting future with an Australian CDC, Centre for Disease Control. Most importantly, I'd like to wish NAPS, its team and contributors a very happy birthday and congratulations on an amazing 10 years. NAPS embodies all the qualities of an effective surveillance and stewardship system. It puts data and insights into the hands of people who can really make a difference, and it's truly data driving action. NAPS is a key partner in implementation of Australia's National Antimicrobial Resistance Strategy. This is really how I fit in. My team's role at the Australian Government Department of Health and Ageing is to provide leadership and coordination on addressing AMR, and it has been our pleasure to be collaborating with NAPS over a number of years. This national strategy outlines the objectives and priority areas to focus our efforts with the aim of reaching the ultimate goal of minimising the development of and spread of AMR and to ensure continued availability of effective antimicrobials. NAPS both contributes to implementing the strategy's objectives on antimicrobial usage and stewardship and on integrated surveillance and reporting. This may not particularly be front of mind when you're contributors contributing to NAPS, but NAPS is also a key surveillance program partner of Australia's Antimicrobial Usage and Resistance National Surveillance System, or what we call AURA. AURA provides essential information to inform strategies for preventing and containing AMR in human health and improving usage across acute and community settings. In addition to NAPS, we operate AURA in collaboration with surveillance partners, which many of you would be familiar and also likely to be contributing to, including the Australian Group on Antimicrobial Resistance, run by the Australian Society for Antimicrobials, both the Australian Passive AMR Surveillance System and CAR Alert, run by the Commission for Safety and Quality in Healthcare, and the National Antimicrobial Utilisation Surveillance Program, run by the South Australian Department of Health. The latest biennial report was released only last week and showed common pathogens are increasingly becoming resistant to major drug classes, with Australia having one of the highest rates of usage in comparison to its international like countries in Europe and Canada. It's critical that AMR remains a public health priority in Australia and that we monitor and respond to threats as they emerge, and we continue to address the inappropriate use of antibiotics where it occurs, and to ensure that the antibiotics that we do have continue to be effective for as long as possible. It's exciting then that public health and how Australia responds to public health threats is now in sharper focus with the Australian government's commitment to establishing a Centre for Disease Control. The CDC will play a key role in Australia's public health space, and we're taking the initial steps to establish a world-class Centre for Disease Control. To deliver better health outcomes for all Australians, the CDC will have numerous priorities, with its establishment grounded in 5 main objectives: to increase independence and strengthen evidence-based and transparent decision-making, to maintain community trust, to improve national coordination of effort with stronger partnerships, including across Commonwealth agencies and between states and territories, to support national action through enhanced national capabilities underpinned by the distinct and complementary roles and responsibilities of jurisdictions, to enhance international connections, and to increase resources to support national preparedness and response. Alongside this work, the Department of Health and Aged Care is progressing requirements gathering for a new national public health surveillance system, including opportunities to partner with state and territory governments and other organisations to link communicable disease and other public health data with other data assets, such as national health and social data. This will form the evidence base for disease transmission, management, and outcomes. An interim CDC will be established from early 2024 in Canberra as part of the Department of Health and Aged Care. The interim CDC will be headed up by Australia's Chief Medical Officer, Professor Paul Kelly, and it's the government's intention that an independent standalone CDC will then be established following the passage of legislation expected late in the year or early 2025, with operational details to be worked through over the course of the next 12 months. The model for the CDC hasn't been decided yet, and there are a range of options under consideration that are intended to improve capability within Australia and integration with the states and territories. A best practice model will draw on expertise we have across the country and beyond. The locations marked in this diagram are just illustrated. Don't read too much into it, but it's just to give you a sense. Exact locations will be the subject of formal discussions by government. But 2 key elements of the structure would be ensuring the CDC has a national footprint to promote collaboration and understanding between the CDC and states and territories, and to draw on existing capabilities, expertise, and technical knowledge across the country via establishing nodes of expertise. These relationships will be integral to the organisation's success. Much like the department currently, states offices may also include staff working on central functions, but it's largely intended that these offices will integrate with state and territory health departments and local communities. We also want to make sure that we're connected to the international community using best case evidence and drawing on international intelligence and surveillance. In an area like AMR, the international perspective will be critical. We're anticipating final decisions on the location, scope, and governance of CDC will be made by government shortly. Once these details are settled, the full funding and resourcing required for the CDC will be determined. Although the scope and functions for the CDC have yet to be finalised, this slide provides some potential options in terms of its possible functions and priorities. As the Australian government has made clear, the CDC's first priorities will be around preparing for future pandemics, leading the national response to future infectious disease outbreaks, and working to prevent both communicable and non-communicable diseases. The backbone of the CDC will be a strong data strategy and data management approach. Right now, Australia's data are fragmented across states and territories and other systems that all have different definitions, systems, and data sharing arrangements. This does not help us get a clear and consistent information for evidence-based decision-making. Improved surveillance, more robust data, and better data sharing arrangements will give us a greater understanding of what's on the horizon so we can better prepare for the public health threats that we will face in the future. One Health principles will be embedded throughout the CDC's approach to disease prevention and control, building and maintaining effective relationships across human, animal, agriculture, and environmental sectors will recognise the interrelatedness of human health, animal health, and environmental health. A particularly important approach for addressing AMR. Through this approach, under the CDC, we'll have a more coordinated and collective effort directed towards combating the threat of AMR across sectoral boundaries. We need to recognise how individual functions all contribute to the overall objective of the CDC, in particular, as we examine future public health threats, pandemic readiness, and response capabilities. It will begin with a systematic, integrated approach to gathering and analysing health intelligence and information. We'll also look at how we build trust in the organisation, including with reporting we publish and share openly. Utilising these data in collaboration with experts across the country, the CDC will develop evidence-based guidance to inform our public health responses. Through this, the CDC will be able to provide meaningful information, guidance, and actionable data advice, actionable policy for government. In addition, drawing on a wider range of societal perspectives, including directly from people with lived experience, will allow the CDC to tailor advice to the public and reach those in most need of it. Underpinning all of this will be a strong reliance on quality surveillance, including the quality surveillance through the National Antimicrobial Prescribing Survey. Quality surveillance that starts with a standardised tool supported by an insightful, inquisitive and expert team like we have here with the National Centre for Antimicrobial Stewardship. Quality surveillance that at the coalface is reliant on the dedicated contributors, the clinicians and practitioners all around Australia who are genuinely invested in driving public health action with data. So to all of you, I say thank you very much for your contributions over the last 10 years in tackling AMR. As we look forward to a future with an Australian Centre for Disease Control, thank you in advance for being strong advocates for the importance of public health and for continuing to join us in tackling the challenge of AMR. Thank you.
Thank you, Christina. And next up we have Noleen.
Thanks, everyone. It's nice to see everyone here today and to those online also. I was told I've got 8 minutes to talk about aged care. What a challenge. 2 parts. Part A, I'm going to talk about the first 10 years, and then part B, what's next, 2023 onwards. Pressing. And so that's not up, yeah. So while Court's helping, move slides, I'll just make mention. So the aged care NAPS was piloted in 2015 and then officially began in 2016. And the aim of aged care NAPS is to both describe infections and antimicrobial use to inform targeted quality improvement strategies. There's two methods. One, on the survey day, all residents are screened to determine if they have an antimicrobial prescription and or have signs and symptoms of a suspected or confirmed infection. It's method one. Method two, same, but in addition, all residents present on the survey day are screened to determine if they've had an antimicrobial prescription on any day during the previous month to the survey day. All Australian residential aged care facilities are strongly recommended to participate. In Victoria, all the public sector residential aged care services are required to participate. Just note, we use the McGear Stone revised criteria to determine if an infection is true or not. Okay, so in 2022, 743 residential aged care facilities participated. That number's increased over the years. The prevalence of residents prescribed at least one antimicrobial was 14.1%. If we exclude the topical antimicrobials, that was 6.9%. Each year I ask myself, is that good or is that not good? So I hope you too, likewise, are asking that question. Well, if I compare ourselves to the HALT study. So the HALT study is those that are undertaken in the European long-term care facilities. We can compare ourselves because our methodology is somewhat similar. And what we find there is their prevalence, when they last did in 2016, 2017, they're currently underway at the moment, 2023 version, but back then, 4.9%. So in our comparison, they don't include topicals. We're 6.9%, so it's fair to say we've got room to improve. But if you're working in aged care at the moment, it's so important to understand the context and background information as to what's happening in aged care, and there's a lot. The number of persons entering these residential aged care facilities is increasing. There was a Royal Commission into Aged Care Quality and Safety that outlined 148 recommendations to significantly reform the aged care sector. We all know, of course, residential aged care facilities were disproportionately affected by the COVID-19 pandemic. Every facility must now employ an aged care IPC lead, and they'll have some responsibilities for AMS. But the big game changer was in 2019. And this is where, for the first time in the aged care quality standards, antimicrobial stewardship was introduced. There's two requirements that are especially relevant, 3G and AT. 3G, where to minimise infection-related risks, that we look to promote appropriate antibiotic prescribing through implementing practices to support optimal care. The other is where clinical care is provided, clinical governance includes antimicrobial stewardship. And that second one is often missed, but is particularly important because what that's telling us is the aged care providers have responsibilities for antimicrobial stewardship in their facility. So 2023 onwards, I dare say, I hope, a lot of you have heard about the NISPAC. NISPAC standing for National Infection Surveillance Program for Aged Care. This is a research project that's currently underway. The aims are to develop a comprehensive and useful infection and antimicrobial use surveillance program for use in the aged care sector. That this national program is both effective and efficient so that it can be confidently used. Ultimately, we want to improve health outcomes for residents, and that we provide a dedicated and secure IT platform that enables straightforward participation. What you're looking at is the NISPAC working plan. The NISPAC is divided into 3 stages, 1, 2, and 3. Stage 1, investigation. Stage 2, development. Stage 3, implementation. Stage 1, we looked at the existing aged care NAPS, more or less. Is it working? Is it not? Stage 2, I'm going to just a few results about the Delphi surveys and show you what the new NISPAC platform is going to look like. The pilot NISPAC I won't have time to talk about, but if For those online or here today want to know more about the pilot NISPAC in 2024, please contact me. I'll give you contact details shortly. So the question I get asked most is NISPAC replacing aged care naps? Well, no, it's really just going to be a one-stop shop to aged care naps and other surveillance modules, a revised version of aged care naps. This is a glimpse at the NISPAC platform. Thank you, Shree, for all your design perspectives on this. I love it. I just look at this all the time. So this is what the front pages will look like. If I just move on again, remembering I'm only allowed 8 minutes, Delphi survey, process measures, important to include, relevant to antimicrobial stewardship, consensus around, we found the presence of defined clinical signs and symptoms, presence of devices, and previous recent antimicrobial therapy, that we should be collecting data about these measures. Around the infection definitions, there was consensus for 11 out of 16 of the infection definitions that were presented. And just note, for the most, it was that we do continue using the McGeer-Stone definitions, but for some there were alternative definitions that the consensus were more appropriate to include. So what are we doing now going forward? Well, NISPAC is, we've got working groups revising alongside the other modules, the aged care naps. And with that, we will be looking at adapting the McGeer-Stone definitions, but importantly, we will also be looking at the appropriateness of antimicrobial use in our aged care facilities. So thinking back to that prevalence rate, that's remaining constant. So we really want to understand how appropriate or inappropriate that prescribing is. I want to thank so many involved in NISPAC and aged care naps. But before I do, I wasn't sure if I was going to share this with you, but when I started in 2015, I don't think I envisaged that at some point our family would be looking to place someone in an aged care facility. And I think it's fair to say when you're a carer for somebody, it's a real insight into how these facilities work. And my goodness, they're amazing. To all the aged care staff online and those here today, you're my champion. You're my champions. My father, I don't go into the facility, of course, and tell them that I'm involved in the aged care sector. I just go in like any other carer, but I do send him to the resident carer meetings monthly and say, ask about the antimicrobial policy and see how that goes. But again, you know, aged care over the last few years has really been on the front of the pages for many different reasons, but I'm here to say they're really our champions in the care that they provide, antimicrobial stewardship also. Contact details, nispac@mh.org.au, but also support@naps.org.au. Again, if you're interested in piloting, please contact us. And we've just had some recent publications that might be of interest to a lot of you. Thank you.
Thank you, Noleen. And next up we have Anna.
Okay, thank you for having me talk about the antifungal naps today. I also only have 8 minutes, so I'll try and be brief. I'm going to talk a bit about how we went about developing the antifungal naps, just briefly. Overview what the antifungal naps is for those who might not be aware of it or might not have seen it yet. Some brief results of the very first audit that we've done and some of our future plans as well. So how do we go about developing the antifungal naps? We started off by looking at the existing literature for antifungal stewardship to see what sort of metrics are used around the quality of prescribing, what sort of audit tools are used and methodologies. We saw there's a really broad range of auditing that's done around antifungal prescribing, and there was no really standardized way to do this. So we then went on to do what's called a Delphi study, similar to what Noleen and her team did, to try to understand of the metrics that are used, what are the important ones, and actually which of those are feasible, what can we do in routine practice. And from this Delphi study, we then went on to do a co-design with a multidisciplinary steering group. We looked at what was important and feasible from the Delphi study. We looked at what existed in the normal hospital naps and what was missing that was important for antifungals. We went and designed and piloted an antifungal naps tool. 8 hospitals took part in that for us, did some testing and provided some really useful feedback around methodology, usability, and we then went on to finalise. And we also did a validation study. So it's important to ensure that the product that we produce is actually valid and reliable, so that if I do an audit today, the results that I get are going to be similar to if Courtney does the same audit tomorrow or next year or next week, or somebody does it in a different state or in a different country, that we're going to be auditing in a similar way. So we did a validation and reliability study to validate our tool. So what we came up with was a flexible audit methodology. So you can use the antifungal naps in a variety of ways. You can do a drug-based audit. So you might be interested in what's happening with your ambisome in your hospital specifically. You can do a unit-based audit, so you're particularly interested in your hematology prescribing, or an indication-based audit, so you might want to see what's happening with all of your candidemias. You can assess each phase of antifungal prescribing, which is important. You can start off by looking at prophylaxis in your high-risk patients. You can then look at empiric prescribing when somebody starts off an antifungal when we don't yet know what the organism is or might be, and then also directed prescribing once we do know what the organism is. Importantly, we collect information about a patient's risk of invasive fungal infection. We gather information about their underlying immunocompromising condition, what treatments they're on, and this helps us to stratify their treatments and to understand where prescribing can be improved. We've added in some antifungal specific quality metrics based on the Delphi study, and also importantly, patient outcome metrics, which are really important here. We've provided some great resources for our users. We have a user guide. As Rod talked about, we have an appropriateness assessment matrix, which is similar to the hospital naps, but with additional factors for antifungal specifically. We put together some instructional videos that are available to anyone to access, an e-learning module, and importantly, some work case examples for people to understand how to use it and how to assess the appropriateness of prescriptions. We also went about developing some reports using Microsoft Power BI and provided hospitals with individual reports and benchmarking reports. And hopefully we can integrate this in the future with NAPS directly, so that users can actually play with Power BI reports interactively, and it gives you really really useful information at the click of a button. This is just a sample of what it looks like today. In late 2022 to early 2023, we launched the first antifungal NAPS. So we asked all hospitals across Australia to participate, or invited them to participate, specifying that you could audit all drugs in all antifungals in your hospital, or focus on key antifungals like ambisome, mold activazoles, echinocandins, or other agents. And we asked them to audit a minimum of 30 prescriptions or 3 months of antifungal prescribing. So we had, that didn't work out, but we had 11 hospitals that participated in our first audit, and we had 514 prescriptions for 407 patients. It was from across 5 different states across Australia, mostly public hospitals and mostly principal referral or public acute hospitals, 8 from major city, and 3 of them were in a regional. So a good variety of hospitals involved there. The way that they chose to use the audit did vary a little bit. So 7 hospitals looked at all of the drugs in their entire facility. 2 chose to focus only on ambisome in their entire facility, and 2 focused on all drugs but in the hematology units. There was a bit of a variety in how they went about using the audit. In terms of appropriateness, so you can see here that the appropriateness for prophylaxis prescribing was quite high at 85%, and directed therapy was also quite high, but empiric prescribing had a lower appropriateness rate. And that's partly because you don't know what the organism is, and so it's not so clear what you should be doing. And then if you go on to have a look and see, well, what drugs were the problem? Really, primarily, it was the fluconazole that was an issue. It's something that's used quite broadly across the hospitals, and not just in high-risk patients, not purely in the haematology or the ICU setting. It can be used in general medicine, in general surgery, and there's really big room for improvement, high rates of inappropriate prescribing for fluconazole. When you look at the top indications for antifungal prescribing, they were prophylaxis, invasive pulmonary fungal infection, and then various Candida infections. And again, the Candida was where the appropriateness was low, and again, very much related to the poor fluconazole prescribing. And our reasons for inappropriate prescribing were most commonly that no antifungal was actually required. So there could have been cessation of therapy there, incorrect dose or frequency, incorrect duration, and just the incorrect drug that were chosen as well, most commonly. So what are our future plans for the antifungal NAPs? We're hoping to do yearly targeted audits for national benchmarking. So because of the data that we've seen so far from the first audit, we're planning on doing a fluconazole focused audit to get a better understanding of what's happening there and to provide some guidance on how fluconazole prescribing can be optimized in hospitals. We will also look to do a haematology focused audit and a pediatric focused audit. So the details of those will come through in early 2024. We will make some enhancements to our audit based on user feedback and findings from the report development. And we want to have those the reports integrated and with the NAP so that users can get really useful insights with the click of a button. And yeah, so that's our project team. And again, if anybody's interested in getting involved in the antifungal NAPs, we'll be releasing more information for next year. But please do get in touch if you have any questions with myself or the team, and also Nikhil Singh, who has been looking after this really well this year for us.
Thanks, Anna. I'd like to make it clear that I told everyone 8 minutes, not just Noleen and Anna. So my talk is about how we use the NAPs, or how we plan to use the NAPs in understudied populations. So for NAPs over the years, as you can see, we've had increased uptake, and we get many inquiries from a range of different services that are interested in the NAPs. And based on that, we've made some modifications, run some pilots, and then implemented new modules like the antifungal NAPs. So first off, talking about our surgical NAPs. So our surgical NAPs is based on a procedure list that we developed in collaboration with the Royal Australian College of Surgeons. And things have changed over the last few years, and we are in the process of collaborating with them to get an updated list that's SNOMED coded, and that'll all be part of our surgical NAPs redesign. But in between now and the redesign, we've had lots of specialist eye hospitals and other day surgeries doing more ophthalmological procedures, and the current list just didn't serve that purpose. So we co-designed an ophthalmological procedure list with them. And more recently, we have other day surgery facilities that include podiatric surgery. So we are in the process of co-designing an additional list of procedures to add to our surgical NAPs list. And that's through collaboration with the Australasian College of Podiatric Surgeons. So watch this space. We've also started collaborating with the Royal Flying Doctors Service. So across Australia, the services are state territory based, and we first heard from the Queensland group. So the process is they reached out to us, we met with them, asked them to tell us about their service. So they do aeromedical retrievals, they have primary healthcare services, oral health, and things called medical chests, which are for very remote services that the RFDS give them this chest of both pharmacological and non-pharmacological devices and medications. And if they need to access the chest, they contact the RFDS and are given that advice on how to use the appropriate things within the chest. So, after speaking with them and what their services and facilities and resources were like, we suggested to give our quality improvement NAPs a try. And they've been using it for 2 years now, and word of mouth got around, and now just recently South Australia and the Northern Territory RFDS have just registered, and we've also received inquiries from New South Wales. And yeah, still using the QI naps. We've also recently been in discussions with family planning services. So there's been an increased interest from them and sexual health clinics. And that's also important to recognise, as there is an increasing STI resistance, particularly with gonorrhea. So there is a need for stewardship in these settings. And we have also suggested our QI naps with them. We've also had engagement from prison services. So there's been some uptake across Queensland, South Australia and Victoria. And again, based on our meetings with them and their services, they are actually doing the larger hospital naps audits. Rod mentioned about our HIF naps pilot. So again, the publication there and some collaborators. So the process for that was that in collaboration with our colleagues, we recognised that hospital in the home was an area where high antimicrobial use was, but with limited AMS oversight. They did a scoping questionnaire to across HIF services to find out what their needs were, and then from that there were some amendments made to the hospital naps. And I'll got the tool on the next slide to show you what they were. They did some feasibility pilots in some smaller services, and then after refinement, that pilot tool was then implemented to over 20 HIF services, and then that's what led to the publication there. There was some costings about what it after the success of it, but there hasn't been any funding to progress this model and make it bigger into an actual online platform. So it just exists on the paper form service. So what that looks like, so if you've seen the hospital naps, it's not too different structure-wise with our HIF naps, but it's got, you know, where was this patient referred to from? Did they develop an allergy or drug reaction during their therapy? Was the antibiotic started in hospital or when they were admitted to HIF? So was the therapy changed to accommodate HIF? What lines were there? Were there clinical reviews prior to and during the HIF admission, and were there any outcomes? And then another collaboration was for Hot North. So that's the publication there, and many, many collaborators here for this piece of work. So this was targeting that, recognising that Aboriginal and Torres Strait Islanders are a vulnerable population, again with limited AMS oversight. This piece of work involved a key stakeholder review, so with pharmacists, those working in the remote services, and ID clinicians. And the amendments were made to our pilot GP naps, which Jo-Anne will talk a bit more about soon. And before they rolled it out, as always, you know, we do the feasibility across a couple sites across 3 states, so Western Australia, the Northern Territory and Queensland, and that then rolled out into a total of 15 primary healthcare clinics for the pilot. And whilst we never did the full economic costings for this, it does exist as a module that we hope to add to the online platform one day. So what that looked like, so similar structure as all our other naps, but what's different is the Aboriginal and Torres Strait Islander status, who the prescriber was, what that expert advice was provided. There was a follow-up on micro from 2 weeks before, 2 weeks after, and highlighting that each state, as part of this pilot, had very specific local guidelines, so recognising that too. We've also had some interest from dentistry. So international studies highlight that about 10% of antibiotics prescribed worldwide are for dentistry. And Leanne Teo, one of our collaborators, did a survey of general dentists in Australia and highlighted that about 55% of their use was considered to be over-prescribing of antibiotics, which represents a key target area of interest for us to improve their use. So in collaboration with Leanne, we are looking at doing a pilot of a dental naps in an outpatient clinic in the Northern Territory. And we also have some Victorian clinics interested if we can get the pilot up and running. So very, very preliminary stages at the moment. And as Rod mentioned, NCAS is One Health, and we're very interested in improving antibiotic use in the veterinary space as well, because antimicrobial use isn't confined to just humans. So I'd like to shout out to our colleagues from the Melbourne Veterinary School that are part of the Asia Pacific Centre for Animal Health: Glenn, James, Laura, Kirsten, Ree, Brian, Susanna, Anna, and Amy. And I believe they've just had a whole influx of more PhDs joining their group as well. They've been part of our team for a very long time. And what they did early on was some small iterative pilots in 2016 to 2018. And they simplified the NAPS data fields, looking at the drug, the dosage, duration, indication, and collection of microbiological samples. But what made it slightly just a little bit different to us was that it also looked at the species level. So we don't do that in hospital NAPS. And what they found was that a NAP style approach at that point in time wasn't quite feasible in vet practices yet. How can we assess guideline compliance when there's not many guidelines? Or there's ranges of other low-hanging fruits in terms of antimicrobial stewardship interventions that need to be done before we start auditing. So there were other approaches that would be more beneficial at that point in time. So our vets, they got to work. They wrote guidelines, they implemented traffic light systems, not just as a resource, but embedded into an implementation trial across, I think, 130 vet clinics. They've set up resources for diagnostic testing, what is delayed prescribing and how to implement it in vet practice, advice on how to develop local guidelines if theirs weren't fit for purpose, and the importance of having a champion. They've developed checklists, they've videos, resources. Their website is phenomenal for what they've accomplished just in their small space. And they're also collaborating with us on a digital health grant on how to automate surveillance for their services too. And these are just an example of some of the many guidelines that they've developed. And then I just wanted to touch on that the NAPS itself, with our team, that may be surprising to many, we're not just experts at unlocking accounts and reassigning survey managers. We're skilled AMS clinicians, and lots of us are researchers with PhDs, Masters of Public Health, Masters of Clinical Pharmacy. We know the NAPS platform in and out, and we're very keen to help our end users with research, with the data that they've got. So we know some people have been doing NAPS for the last 10 years, and they have lots of local data but might not have the time or resources on how to do it. So NAP support isn't just unlocking accounts and, is this Careflex script appropriate? We can help with your research as well. So the tip of the iceberg is that our team, yes, we develop these annual reports and the circulars, but we will by this year have 1 million prescription data points, which we are very, very keen to help people do research. Whether it's looking at a specific indication, a specific antimicrobial, we have the ethics and the skill set to help you at your facility get your local ethics to publish and highlight all the work that you do for NAPS at your facility as well. And that'll do me. So I'd like to introduce Jo-Anne.
Okay, just that one? Okay. It's been interesting to see all the technology going today. So thanks very much for the opportunity to speak. So my name's Jo-Anne. I'm an academic GP based at the Department of General Practice and Primary Care across the road at the University of Melbourne. And we've been collaborating now with the National Centre for Antimicrobial Stewardship for about the last 7 odd years now. And I just wanted to give you a little bit of context to our program of work. So approximately 9 in 10 Australians visit their general practice every year, which means that most Australians receive most of their medical care in the general practice setting. And as was mentioned earlier, if we
were to combine Australia with the European countries, we currently rank about 7th in terms of the highest countries with antimicrobial prescribing. Now, back in 2019, data from NPS Medicine Insights showed that around 31% of Australians attending their general practice would receive at least one prescription for an antimicrobial each year, which we know is high. And the prescriptions are often given for conditions like upper respiratory tract infections, where they're likely to make no difference. And in fact, it's a problem because that results in over-medicalisation of otherwise self-limiting conditions, and obviously also to things like antimicrobial resistance. Now, we've heard today about AMS strategies being embedded in hospitals and aged care settings, but really we've had no ongoing program, AMS program in general practice, despite the bulk of antibiotic prescribing occurring in that setting. And so whilst we're here celebrating the 10th birthday of the NAPS, and we're a lot more in our infancy, we're the tiny little cupcake to what I hope is a very big cake later on today, Kaz. But I'm hoping that just even thinking about those statistics, everybody will recognise that actually primary care deserves a much bigger slice of the AMS cake at both state and national level. So, of course, I'm going to be talking about a tiny bit of the work that we've done. I just want to acknowledge that there's been a very big team of people that have been working on this. This is some of our all the clinicians that have participated in leading the program, but they've been really well supported by a health informatics team from the Department of General Practice and Primary Care, but also the IT team at Melbourne Health, without whom we couldn't have done a lot of the work. So we've started off with really quite small work, qualitative work, through co-design simulation studies, through to our pilot general practice AMS quality improvement program, and now working with the broader teams about how we can look at automating guideline compliance and assessment to bring things to scale. But just very briefly, through talking with GPs, we know that the current use of antibiotic guidelines and their electronic medical records does not support optimal antibiotic prescribing. You don't have antibiotic guidelines integrated within the electronic medical record, but GPs do actually want to be part of the solution. And there's a lot of things that are low-hanging fruit that we can use to address some of these challenges that they're experiencing. But it's very hard to know what to change if you actually don't know what your prescribing activity is. And in fact, in a lot of the software that's provided to general practices for auditing, it's actually not capable of looking at antibiotic prescribing. So really, we don't have the tools that we need to make improvements in this space. But back in 2017, our roving AMS pharmacist, Robin Ingram, went across 11 general practices across 3 different states and audited antibiotic prescriptions. And we did this for a few different reasons. One was to see, could we apply the hospital NAPS methodology to general practice? It was also to determine acceptability, but it's also to look at where we can pull the data from the general practice electronic medical record to make these audits happen, because it's just not going to be practical to have pharmacists going out to every general practice across the country when there's more than 6,000 of them. And what we've learned from that activity is that GPs liked the customised NAPS reports. They liked having the opportunity to talk about the audit and feedback data with some experts in the space, but just as importantly, to be able to discuss with their colleagues who were actually low volume prescribers how they had managed to achieve that. So a lot of benefits from reflection and shared learning. But we learned that they liked it. That was the most important thing, because volume doesn't matter to GPs, but appropriateness actually is meaningful to them. And this was the only program really that had offered them that insight. And so they wanted more, which was obviously great for us. And we were very lucky to get support from Therapeutic Guidelines and the RACGP Foundation
to move what we had learnt in those initial projects into a pilot program in 3 general practices here, which we did together with the Northwest Melbourne Primary Health Network. And so we had some baseline audits, feedback reports, quality improvement activities with CPD points attached to them, and enabled that quality improvement activity, which for some miracle we managed to do despite a little problem that came up in the middle of that called COVID. The important thing though was those practices did not have to fill in any forms. We extracted the data from their electronic medical records, and if they didn't put in a reason for prescription in this particular project, we had a little prompt that that popped up so that they could record that for us to allow us to do those appropriateness and compliance assessments, which allowed us to provide some meaningful feedback. So they were able to compare themselves to what was happening in the practices overall. They were able to look at their compliance with guidelines and their appropriateness, and to consider some feedback about what they were doing really well and what could be improved. And we were able to give them a number of different resources that they could put into place in their practices to facilitate that. So the GP reflections from this is that they increased their use of guidelines. They changed how they prescribed in terms of things like duration and the use of delayed prescribing. And they more actively use patient education and resources to have something to give to patients when they actually didn't need an antibiotic, but still had some information that they could give to that patient about self-management and care. GPs said, is this data correct? And we were able to actually show that using data from the electronic medical record that's extracted rather than doing an in-practice audit with access to all of the records actually did have acceptable accuracy. And then we do need to be able to automate this. So we have done some preliminary work together with Daniel Capurro, who's in the audience here today, and a master's informatics student, to do some initial trials of some machine learning techniques to see how we can more efficiently determine things like compliance assessments. So what does the future look like? Well, I think applying new techniques like machine learning to automate some of these compliance and appropriateness assessments, and being able to get access to data in an ongoing way through electronic medical record vendors is important. We've only looked at general practice, but very soon pharmacists are going to be able to be supplying antimicrobials for urinary tract infections. And so having some kind of feedback for our colleagues in pharmacy, I think, is really important to be able to support them as they start on their journey with providing antimicrobials without a prescription. And then the last thing is, primary care really does deserve a bigger piece of the cake. And I know that the whole AMS community needs more funding, but if we're not supporting a part of the health system where most Australians receive their care, then we're really not going to make the differences that we really want to be able to make. So thanks very much.
Thank you, Jo-Anne. And up next we have Ron. Oh, how pretty.
Right, good afternoon, everyone. Now, as my first slide with my hideously beautiful word art says, I'm here to talk to you about how NAPS has gone global. Just before I begin, I just want to give a big shout out to my UK Fleming Fund Fellows online. Hello to all of you. All right, so NAPS goes global. So from our humble beginnings in Australia, we're now rolled out in 13 countries, but I'll talk about the last one. So I've only listed 12 there. But as you can see, it's a very diverse number of countries. Some are LMICs as well amongst them, and some are as pilots and some as national programs, as you might already know. So what's the success behind this? I think we've already talked about this, and I think you're already quite aware. NAPS is a very feasible and practical audit. It gives you data that you want. It's fairly easy to do, and there are different modules that you can take on. You can do it in many different ways. The other thing, the results are generalizable and translatable, which means that you can apply it to different settings. You can put it, in a big hospital, you can go rural, regional, in many different ways. I think what really sets us apart, I think we've already talked about this, is that we are very unique. We're the only one that does appropriateness assessments in this way. All right, so I guess implementation is something we should really talk about. It's implementable. So I think a lot goes back to our dedication to our users. So we can create dedicated portals for each country, so you can manage it the way that you want. Our training, we have e-learning online and in-application training videos, because we understand that there is such a thing called time zone, so we can have to do it in different ways. And we can adjust the database on the other end, so wording changes can be made to suit your local context. We've added new antimicrobials, routes, frequencies, classifications for auditors and facility types, because not everyone's the same, and added lots of indications as well. And like I said before, we provide really good support. I think that's what our users have fed back to us, and that's what underpins our success. I've seen CAS have meetings early in the morning. I answer WhatsApp messages late at night, and emails all throughout the day. So I think it comes down to our passion for our work. I'll present a couple of case studies to you. So this is from a publication with our collaborators. So Rod led this work. So in Canada, there was this was rolled out in 2018 with 38 hospitals on board and funded by the Public Health Agency. I think at the last time, I think it was 100 hospitals have registered, so it has grown since then. This came out of a need of a lack of data standardization and a need for guideline compliance and definitions of appropriateness that could be applicable to any patient population. So what worked was it was flexible, so they liked the 24/7 availability of the platform. It was a standardized tool and relevant to many different hospitals. Again, it's quick, and I think the reports could be generated immediately. So it's timely reports that could be fed back to the users, and they like the benchmarking and trend identification as well. The other case study I'll present is Bhutan. So this is led by Pem, who's one of the UK Fleming Fund Fellowship Program fellows. She's a big champion of ours. So the aim here was to meet with the National Action Plan to develop a surveillance and monitoring system for antimicrobial resistance and use. So 4 hospitals surveyed using the hospital NAPS with bed numbers from 60 to 150. Training was provided by our NAPS team here, and oversight was provided for the initial set just to make sure everything was going all right. And what they liked was, again, they liked that the survey data was locally owned. It was flexible, suitable again for many hospitals. They liked the web-based platform, so it didn't rely on their local IT. It was practical again and meaningful for AMS programs. They liked the appropriateness metric. And because they don't have many guidelines at the time, the appropriateness metric was an added bonus here. And again, reporting, possible, it was immediate, possible even in the absence of local statistical support. And the last case study I'll present here is Pakistan. So Pakistan, there was a consumption audit conducted in the KPK province and revealed a high consumption over time. And as we all know, province audits are the gold standard, but this is not always feasible. So again, driven by the Fleming Fund fellow Atifa, she decided to go ahead with the QI-NAPS, train the staff locally on how to conduct the QI-NAPS. So QI-NAPS, if you don't know already, it doesn't require an appropriateness assessment, but it uses guideline compliance as a metric there, and quality of use metrics. So it can be done by most people. You don't have to have expertise in AMS or ID because you're just checking against a guideline or against the prescribing quality metrics. So they found that these were the findings. I won't read it out to you. And the results were presented at the AMR Symposium early this year, and also at the Antimicrobials Conference in Brisbane, and that's Atifa there. Now, it's a couple of happy snaps. So on the left, you can see that's our colleagues in Fiji just last week doing the NAPS in country and presenting the results. In the middle, we can see Atifa there in action in Pakistan doing the QI NAPS. And on the right, that's Rod and I in Timor-Leste doing the NAPS in the National Hospital. And that's Agatha presenting, they're rolling out the guidelines actually in Timor-Leste at the moment. So it's all, lots of exciting things happening at the same time. So barriers, this won't be complete until we talk about some barriers, I suppose. So lack of national guidelines, we know, is a barrier to performing this sort of audit, but the NAPS does overcome it with the appropriateness assessments. And in every setting, funding, expertise, and time are always going to be barriers, but we know these things already. So I guess the next stop, Portugal is the number 13th country that's been rolled out recently. There are 9 hospitals currently enrolled. The data collection is in process. It's the first ever translation into a different language and cultural adaptation of the NAPS for the appropriateness assessment definitions. There's been validation by clinical vignettes and back translation done as well. and the additional translation of the NAPS resources and user guide into a different language. So very exciting. Courtney's been helping Carlos in Portugal with this. And the other thing is we're going to be taking a regional approach as well with our recent partnership with the International Vaccine Institute on Capurro 2, rolling out in South and Southeast Asia. So it is quite exciting work. Yeah, that's concluded my presentation. Thank you.
Thank you, Ron. And now we have Daniel.
All right. Thank you, everyone. Thanks for having us here. I think it's been amazing to hear everything that's been happening with NAPS over the years. We're latecomers. We just started collaborating a year and a half ago, and working on this area of machine learning. So that's what we're going to talk about. More about are we there yet? Because we are just starting to get access to the data, so we haven't been able to really produce anything to show off here, but it's coming. And again, this is something that we work together with Vlada, which is the actual person that knows about AI. So first, when we think about AI-powered NAPS, what do we wish for? And we wish for data to be captured in a simple and non-interruptive way for clinicians, where missing data can be inferred from the patient's context, where there's simple and secure access to real-time prescription data, which can be automatically and accurately classified in terms of its appropriateness and its meeting guidelines, where meaningful feedback for clinicians can be provided, which fits their clinical workflows and leads to sustained improvement, and all of that easily updated. Okay, so we are not there yet, definitely, because we still rely on doctors entering information. I've seen doctors entering a dot in a field that's mandatory just to get to the next screen. So we still face a lot of hurdles. Okay, but we think that with some smart use of a few tools, we might be able to slowly get closer to that. So again, for this question of are we there yet, the answer is not yet, and it's a long and winding road. But as you've seen, NAPS started very early with a paper survey, and now it's going global. So again, in 10 years, there's a lot of progress. We hope that we'll be able to make a lot more progress in the next 10 years. So what are we working on? We're working on this, very simple pipeline that we started drawing on a Miro board that, had like 3 different components. It was like, oh, we start with the raw data, then we move on to the clean data, and then we assess. Everybody's happy. Now this board has grown into this monster beast of pipelines and workflows and assessments, but it's still the same principle. How do we go from the raw data to clean data and then to an antimicrobial appropriateness assessment? The challenge here is that we're not just working with human data, we're not just working with hospital data, but we're working with GP data, as Jo-Anne described. We're working with hospital data, and we're working with vets. And if you have worked in any health information system, integrating data from 2 different hospitals is a challenge. Integrating data from hospitals and vet practices, I'm sure it's going to be a bigger challenge. And that's what we're trying to work on now. And we're using some informatics tools to make sure that we can clean that data and doesn't require heavy investment in human resources to actually clean the data and finally do the assessment. But we've done some pilots, and this is Jo-Anne briefly described this. We worked on these assessments that had been done by the NAPS survey. And this was a data set that was manually curated, and I'm looking at you, Ruby, And it's underlined because there was a huge amount of work to get that data into the right shape. And we trained a random forest, and we calculated the sensitivity and specificity for accessibility and appropriateness, and we got pretty good results. And underneath there, and that was one analysis that was done by Alistair Quinn, one of our master students. So we were really happy, and that was one of the things that encouraged us to apply these methods to hospitals and vet practices as well, which again, we're not there yet. But the question that everybody's asking me is, what about large language models? Because these, in the last year, and when we applied to this MRFF grant, ChatGPT wasn't around. But now everybody's using it and sending prompts and getting feedback. So I would say it's a work in progress. And it's currently not allowed for clinical uses in Victoria. It has been so far explicitly, forbidden. So it's all in the research space, but it's rapidly evolving. But I just wanted to go through an exercise with you guys today. So this is an example, and I hope everyone can see that. So this is the example. Let me just quickly. I can't.
Yeah, you can still navigate to the.
Oh, no, not yet. But
Okay.
Just going to read this. So I'm a physician admitting a patient to the ward. The patient is 78 years old. She's coming with a history of 3 days of feeling tired. She woke up confused. The husband called the ambulance, who brought her to the ED. There's no history of respiratory or urinary symptoms. The patient has a background of type 2 diabetes and hypertension. When I see the patient, this patient looks tired and disoriented. Vital signs are normal, no fever. Physical examination is unremarkable. Normal chest x-ray, elevated leukocytes, elevated neutrophils, normal kidney function, mild hyponatremia. So a typical gen med patient. Blood cultures and urine, MCS were obtained. They're still pending, but the urine shows nitrates and negative leukocytes. The cultures are pending. I think that the patient has a urinary infection, and I prescribe oral amoxicillin for 7 days. So that was my ChatGPT prompt. Let me see if I can switch to the. All right, there you go. So scan the QR code. That's gonna take you to the first question.
So let everyone in the room do that, and then everyone online has already access to this screen. So
Okay.
just give everyone a couple seconds to do that, and then we'll go back to Keith.
Is this one? Or
No, because that's
Yeah. It's asks you a question. So the first question is, so you can think meanwhile, was that prescription appropriate? So I'm going to ask the humans in the room and online. Can I go back to the case? You're driving us crazy.
Has everyone logged in? Yeah, perfect. Okay, so now we will go to share this screen.
Do you want the case again?
Yeah.
Ah, okay.
Oh, forgot the case. Okay. So let's go back.
Let's go back to sharing this one. All right.
I thought I was going to use less than 8 minutes, but okay.
While everyone is, so we will now share that. Why is that not? I'll just stop sharing again.
Just share it.
That's up there. There. It's weird that works.
Okay.
No, wrong way. That way.
Wrong way. Okay, so that's the case. So a patient, suspected urinary tract infection. She's coming to the ED, brought by the ambulance. Diabetic, hypertensive. She has a mildly abnormal urinary sediment, and somebody prescribed 7 days of oral amoxicillin. All right. So answer the first question, please. Can we go back to
So now
this
we'll
one?
go share that one. Okay. Now we want to share these.
And it's okay if you don't know, that's okay. Just answer whatever you think it's the correct answer.
For the purposes of this, the people in the room can't see this, but
Oh.
you can tell them what it is.
Okay. You can see the results?
Online, everyone can.
Oh, on the
On your
phone you can
phone.
see?
Oh, yes,
Oh,
you've got
perfect.
it.
So I don't need to show you. Oh, that's amazing. All right. So the first question was this prescription appropriate? And we have 36 people answered. So hopefully most of you already did that. And then the second question is, it should be like a little arrow.
Let's go back to stop sharing. Yeah.
Oh, there it is. And then I'm going to show you after this. Then the question is, do you trust what ChatGPT is going to assess? So a majority,
Straight away.
somebody said no straight away. No, but I'm not going to give you the answer. I'm just asking about what you think that's going to show up. So I did the assessment, and then do you trust what I'm going to show you afterwards? Okay, so 30 said that it was a wrong antimicrobial prescription. 6 said that it was the right one. And here we have, a majority saying that you don't trust the assessment. Is that fair? Okay. Everybody finishing? Okay, let's go
Back to the PowerPoint.
back to the PowerPoint.
Okay.
No more Mentimeter for today.
Okay, stop share. And go.
All right, perfect. Yes.
Let me just go to.
Oh, there it is. Okay. All right. So this is what ChatGPT said. Based on this scenario, while the diagnosis of a UTI seems appropriate, given the patient's presentation, the choice of amoxicillin as the first-line treatment might not align perfectly with current Australian guidelines, especially if local resistant patterns are not favorable for amoxicillin. The duration of treatment appears reasonable for a presumed uncomplicated UTI, but this may need to be adjusted based on the culture results and the patient's clinical response. So I think I was pretty surprised. I hadn't done it before. I did it for this exercise. Then I started trying more complex scenarios. So this patient was not immune suppressed. They hadn't had previous infections or previous cultures with resistant agents and so on. But again, it's a little bit, I was slightly surprised. But then I did a different experiment. I said, can you create a cartoon describing our project? So the description was, can you create a cartoon of an AI agent helping doctors or clinicians prescribe antibiotics to patients and pets? And these were the results. So you see here on the left side that you can still see, a few weird things coming up. So first, there's this language, which I don't really know what it is. At the bottom here, you see this dog that has one head and two bodies, and it's eating pills of antibiotics. Okay. And then I said, can you create like a minimalistic version of this? And he created the one on the right. And you can see again other weird things like this giant dog. At the top left, there's like this uterus. I'm not really sure. And this tiny cow on top of a cart of antibiotics. So again, I think we're probably not there yet in terms of the ability of generative AI to help us. But again, this technology has been advancing so quickly that it may change the way we do automated antimicrobial assessment in the in the next 10 years. So again, thank you everyone, and happy birthday to Naps.
Thanks, Daniel. I think we have some new designs for the UI for the new NAPS 3. So yeah.
And next up, we have Caroline, who you will all know.
That'll be our NAPS design for 2033 renewal.
Yep. And then just here.
Yeah. Okay. All right. I'm Caroline, and I've had the really great pleasure of seeing how far the NAPS program has grown over the last 10 years, and it's my very great pleasure to also talk about what we envisage the NAPS program to be over the next 10 years. So Rod's gone through this history. I will go through this quickly, but just to say that in that period of time, from a cosmetic point of view, our logo has improved, but probably the one thing that literally has not changed at all. And when I found the photo of Kaz wearing the same dress, a short one when she did back in 2013, I couldn't resist, so I'm sorry. But in all seriousness, all of this is happening on a background of changing resistance patterns, and so antimicrobials, organisms that were very susceptible to antimicrobials 10 years ago are now no longer the case. But I suppose on the flip side is that we did see with the latest AURA report that with collaboration and a combined effort, there have been some real improvements in terms of the susceptibility of organisms, talking about MRSA. And so that all the work we do is not for nothing, and it does have real improvements in terms of being able to improve patient care. I think in order to understand where NAPS needs to go over the next 10 years, it's really important to understand what digital health has been. And I really love this diagram because it shows in a very simplistic, conceptual way the growth of digital technology in healthcare in general. And when NAPS first started back in 2013, most hospitals were still on paper records. I suppose the relative digital literacy amongst healthcare professionals and in the general population was relatively low compared with where we are now, where we're seeing this exponential increase in the pervasiveness of digital technology across healthcare and across healthcare professionals and of course in the general public. There are many millions and billions of data points everywhere and quite sophisticated analytics that can help us interpret and gain knowledge from this. In terms of where the AMS landscape is heading, I think probably irrespective of a country or an organisation's level of digital readiness, the core principles of AMS will remain the same. So things like the right antibiotic at the right dose for the right indication, etc., will remain critically important. And the key tenets of meaningful audit and feedback, having correct data presented in a way that is actionable with good data visualization, and this emphasis on meaningful engagement with clinicians to improve prescribing will remain. However, in organisations and countries that are digitally ready and have good technical infrastructure, there are some really exciting opportunities for AMS. And the whole area of AI, machine learning, not just in assessments of prescribing appropriateness, but also in electronic clinical decision support is really exciting. This concept of automated data extractions from electronic medical records, which increasingly most healthcare facilities, certainly around Australia, are increasingly adopting, and the ability to aggregate multiple data sources across organisations and health sectors, as well as this kind of increasing focus now on a personal health record and empowering a patient rather than it being organisation-centric. Oops. So what are the opportunities for NAPS? Well, I suppose it's difficult to know exactly where we'll be in 10 years' time, but we have a really great opportunity to lay a very, very strong foundation now. A lot of what we're doing with the NAPS program over the next few years will be designing for varied needs of clinicians, of healthcare settings and countries, and it's important that the NAPS remains flexible and adaptable, but also incredibly robust. We really want to place emphasis on simplifying the act of auditing so that auditors can spend time engaging with prescribers rather than manually putting in data. And a lot of emphasis on intelligent reporting, really good data visualization is a key focus. We do also want the NAPS to be more than just a simple survey or an auditing tool. We want it to be able to support AMS more holistically from a program point of view. And as Ron has mentioned, we've got a lot of focus on supporting AMS within the Asia Pacific region. The system needs to allow linkages with with other different systems, and hopefully at some stage we'll achieve this holy grail of being able to triangulate antimicrobial usage, antimicrobial consumption, and resistance to data, ideally in the one visualization. That would be amazing. So this is the aim of the NAPS rebuild, and I think core to all of this is ensuring that we cater for all the different levels of the NAPS program. It's not just about research and national surveillance, but fundamentally about making sure we have a tool that supports local quality improvement. The NAPS rebuild will have these 4 core components, which I'll just very briefly go through. And I think the first thing underpinning everything that we're doing in terms of development is a certified ISO 9001 framework and a quality management system. The NAPS is not a medical device, but with everything that we've learnt through developing our guidance application, we'll be incorporating all these other ISO standards as part of the best practice. This whole cybersecurity data privacy area has come a long way in the last couple of years, and so this is really a key focus in how we're designing NAPS. In the coming months, we'll be implementing multi-factor authentication for all of our users, and also we're very mindful that different countries have very different requirements in terms of how their data is stored, because it can be quite sensitive health data. We are building the whole entire thing again from the ground up, and we've got our technical team led by Logesh, who is leading our NAPS development, Abukari, Pramod, also Simon Burrell. It will be a cloud-hosted application, which will allow us to scale and have more efficient development of future components, allow those future data linkages, and also have in-country onshore hosting of data for all of our international participants, which we're hoping to expand. And from a user point of view, this is probably what you're most interested in. These are all the things that you will see when you're interacting with the NAPS platform. So the UI design and the user flow will be completely different, and my thanks to Sri for all of her amazing work in advising us with that. It's much better having her design it rather than us clinicians trying to figure out where things should go. So thank you. We know that we have additional user roles that we need to cater for. A lot of emphasis on this kind of interactive BI style reporting rather than the static reports which you're used to, being able to directly, not directly, but being able to import extracted data from an EMR and directly do the mapping within the NAPS system to speed up the auditing process. All of the clinical content is currently under review, and we will be launching an updated appropriateness assessment, which we'll be telling all our users about in due course. We do also want to have this greater level of customization, syndrome-specific questions, as well as clinical care standards. And we're also incorporating an antimicrobial stewardship readiness assessment and scoring system, which we've developed over at NCAS over the last few years. And as Courtney alluded to, in terms of the rich data set that NAPS has at the moment, being able to provide direct access to our research data platform for research purposes and jurisdictional reporting. A very brief sneak peek of what the new NAPS will probably look like. It looks a lot better than what it is now. But this will be an example of an actual audit with a list of patients and the ability to manage all aspects of that audit. This is an example of a patient record with the ability to capture patient details, individual antimicrobial details, and also to have an indication level summary at the end of that with an overall indication level compliance with guidelines and appropriateness. This is our initial work on the data import functionality, but the main thing is that you'll be able to do all the mapping to the NAPS master lists within the system itself. And at a program level, we're on the one hand trying to be more strict with our national data collection periods and the locking of historical survey data, as well as retaining flexibility for auditors who need it, having simplified annual reports and putting emphasis onto these quarterly circulars, which hopefully many of you will have seen. So our next 10-year challenge in coming into 2033, I suppose we don't exactly know what it will look like, but these are the sorts of things that we hope we'll be able to achieve for the NAPS program over the next 10 years, being embedded into the new Australian CDC, international expansion, increased work with EMRs, being able to incorporate some level of machine learning linkages with other platforms, and being a really robust One Health research data platform. This is what our team looks like today, and who knows if we'll all just be chatbots in 2033. But I think irrespective of whether or not resistance looks like this in 10 years' time, or hopefully a bit more like this with all the work that we're doing, I think the key NAPS philosophies of meaningful data for meaningful action will always have a place. Thank you.
Thank you, Kaz. Now,
just before we break for our cake and sparkling, we just want to mention a couple of things just while we're quickly getting the slides. There are a couple of people that we just wanted to say a few words about. Yes, this one. I've got that one. Yes. So
wait, it's not sharing yet.
So there's Marion Robertson was one of the earliest pharmacists at the Royal Melbourne Hospital that was probably the first stewardship pharmacist. And was very instrumental in building out really the early adoption of approval systems and working with us on the NAPS. And it was very sad to hear that she passed away last week, wasn't it? So we thought it'd be important to remember her. And then the second person is Kathy Milady, who many of you know from the Australian Commission, who is a great advocate for our team from the get-go and recognised the strength of our team and helped to drive forward the adoption. You know, a few thoughts for Marion and Kathy. Now the thank you slides back. Okay.
Yeah, it's not there.
It's impossible to thank everyone. Really, it truly is. It's really sad that Kirsty couldn't be here because she's been such an amazing driver with me for a long time and was really one of the inaugural people working with guidance. My whole team that are here today, hopefully you can mingle and meet them, but they are really quite an extraordinary bunch. And in particular, shout out to Rachel, where are you? Who has been working, there you are, a newest member of the team who has been working tirelessly to set up today. The technical team, the operations team.
That's all right.
Yeah, fitness, the whole lot. So really, I don't know what to say other than the fact that it's been an extraordinary ride. I'm incredibly proud of what we've been able to achieve. I really do think that we've made a difference. And, you know, as a digital and health services research and a physician, you know, you can't ask for anything more than knowing that you've made a difference and that people that are continuing to use a voluntary program and keep coming back to us and saying, well, what's next? What's happening next? And, you know, my own team saying, what are we doing the NAPS this year? And, you know, it's actually really quite exciting. So thank you all for coming today, Christina, Robin, Nadine Hillock, who is a wonderful advocate who leads the Norse program in South Australia. Thank you so much for coming across. It really means a lot to us. And poor old, we've been in so sort of distance with COVID and everything. Nadine actually met Rod for the first time. So the last little thing is something that we wanted to give to Rod in recognition of your
This camera here.
This camera there.
There, yeah.
We've got a
and some wine.
Thank you, sir.
Happy birthday.
It's not in front of the, no one could see that. No one on my.
Because I'm collecting the thing.
Wow.
Hey, how did you know, Trey?
Sorry.
Thank you, everyone. Do you think we should sing Happy Birthday before we go and have cake? Ready? Happy birthday to you. Happy birthday to you. Happy birthday to you. Happy birthday to you. Hooray! Thanks all of you online. Oh, look, there's lots of, you know, those you know, the party thing's
Zoom
coming.
thing.
Thank you so much for joining. I hope you enjoyed it. We have recorded it. Oh, look at them all. Oh, can you see them all? Looking forward to catching up with you soon. And thank you for joining. And I'm sorry you're not here to enjoy the naps cake, but we will post a picture of it actually, because it's pretty hilarious. All right. Bye, everyone.
Thank you, everyone. Thanks to those online.